All right. Can everyone hear me? If I can get someone in the chat screen to just let me know that. Excellent. Great. So I see some familiar names in the chat. So always a pleasure to see you guys. And thank you. And for those of you who are my patients, I don't know if I'll be teaching you anything new, but I do appreciate your support. It does mean a lot. And I want to thank everybody for joining today. My name is Brad Klein. I am a physician at Abington Neurological Associates, and I have a few other hats, including the director of the Abington Jefferson Headache Center. And I'm also a clinical professor at Thomas Jefferson University, Department of Neurology. So tonight I have the esteemed, or today I have the esteemed pleasure to discuss a little bit more about headache disorders. And the agenda that we have for this afternoon is to explain first why this diagnosis matters, and then go into a little bit about that headache is a disorder that's really common, and there's different types of headaches, but I think you'll find that one of these particular headaches, specifically migraine, is extraordinarily common, and it's amazing how many people have these different symptoms of numbness or tingling or vision problems, or the headache can go one side to the other. And for the first visit, it's common that they're often surprised at how frequent and frustrating it is, that they have this, in addition to the fact that they don't realize how common this problem is, not just across the country, but on a global scale. And I want to make sure that everyone, by the time that they leave this conversation, recognizes that you're really not alone in this process. And not to tell you the end of the lecture, at the beginning, but spending a fair amount of time discussing specifically migraine of the different headache types, because it's so prevalent, so common. And then we'll explain a little bit about what it is and then how to treat it. I will also comment that at the end of this presentation, there'll be an opportunity to go through some Q&A through the chat box. So if you have any questions that come up through the presentation, just write them down, and then I'll be happy to try and address any questions that you have, before the 1 o'clock hour comes up. Okay, so oftentimes patients will come in for that first visit, or I'll see them in the hospital and I say, okay, well, okay, you have this headache now, and tell me about your history. Do you have headaches beforehand? And they might say that to me that, well, I have a history of headaches, no big deal. Well, for me, it actually is a big deal, because it's important to understand the type of headache that they're dealing with, because different headaches have different impact on the particular person. And I kind of look at this like the animal kingdom. Like, we're all part of the animal kingdom, but are we a human, a lion, a tiger, a bear, a monkey, a porpoise? Understanding who we are and breaking that down a little more thoroughly has a lot of value to try and figure out, well, what disease are we talking about? And then what's the best treatment? So it's really of great value to clarify that, just like when you have hypertension or diabetes or high cholesterol problems, the medications that we might use for those different problems are entirely different. And just like that's the case in those diseases, in the world of headache, there are actually significant differences depending on the diagnosis that we come up with. So that clarity is of great value to myself as a headache specialist, as well as a neurologist, as well as to your primary care providers. But it is complicated, because the reality is in order to clarify what's wrong with an individual, it really takes some time to understand the history, do an examination, and really spend some time with the individual to try and clarify what the challenge is. And as John Ed Meads once said, who was a famous headache doctor who passed a couple of years ago, it takes a patient history, it takes an exam, and it takes time. And so far, there are really no safe shortcuts. And probably one of the challenges that providers face across the country, if not the globe, is there's so many different types of causes of headaches. And, they can be related to many different illnesses. And, when you think about the possible causes of headache, it really is one of the largest, longest symptoms in medicine. And particularly for some of the headache disorders that we deal with, there's no objective tests. Unlike in diabetes, if your hemoglobin A1C is elevated, you've got a diagnosis. Or if your blood pressure is elevated, again, you've got a diagnosis. In the world of headache, it really comes back to that history and knowing the key questions to ask to get to the right answer. And so when we as providers are looking at a patient, generally, one of the things that we will do is to try and get that diagnosis is, again, we'll take that history and examination, and then we'll look for red flags. And red flags are concerns that drive us to think that maybe there's a secondary concern, tumor, strokes, things of that sort. If a person has never had a headache in their life and now they're in their 70s or 80s, that would raise a concern. That would be a red flag to us versus in their 30s or 40s, whereby headaches are much more common. If they have wake-up headaches, then that would drive some concerns as well. If they have acute debilitating headache out of the blue, like a thunderclap quality, whereby they go from 0 to 60 and within 5 minutes, that would raise red flags as well. Or they have some focal neurological deficits, that would also raise red flags. And in that context, what we would do then is we do a number of different diagnostic tests to try and look for possible reasons why that particular individual might have a headache disorder of concern. Usually that will include an MRI brain with contrast if possible. Maybe that includes an MRI of the neck. Maybe that includes a sleep study. That will include invariably lots of different labs looking for metabolic concerns, because thyroid concerns could play into causing headaches as well. If we don't hear about those red flags, traditionally speaking, we would consider that this might be a primary headache disorder, and that could include migraine, tension type headache, cluster headache, and then there's a litany of other primary headache disorders. And when I say primary, it means that it's not due to a secondary cause like ischemic stroke or tumors or infections in the brain and things of that sort. Now, one of the concerns that comes up very commonly is that people will have this debilitating severe headache. And they're like, okay, well, it's got to be something big, bad, and ugly. And in fact, many of us as providers, again, thinking about red flags, we want to make sure that there's no large concerns. And what's fascinating is that this is a study done in 2006 by a gentleman by the name of Jeff Goldstein, who looked at emergency room records of millions of records across the country. And what was discovered is that ultimately, when people came in with the most severe headache of their life, or just a really challenging severe headache that they couldn't get under control at home, the vast majority of patients actually did not have a secondary headache disorder. In fact, when you're thinking about strokes, tumors, and bleeds, only 2% of the patients in this particular study actually had a headache disorder of significant concern that need to be addressed by some additional means versus a primary headache disorder, as I had mentioned before. And that suggests, as you can see here, that 64% of patients basically were diagnosed with migraine. Another 20% were diagnosed with benign headache. And what that really means is that the provider, unfortunately, couldn't figure out what the right diagnosis was. Maybe they were uncomfortable making the diagnosis of migraine, or they weren't familiar with the classification. But I would bet that that was more likely the case than not, which means that you're talking, about 84% of patients coming into the emergency room with a severe headache actually ultimately turned into migraine more likely than not. Not to say, of course, that if you're that 2%, it's 100% to you. So as a patient, I certainly wouldn't blow off a severe debilitating headache, particularly if it's new and unusual for you, or just doesn't go away. But I can tell you that statistically speaking, the vast majority of patients will actually have a primary headache disorder, not a secondary headache disorder. Even when you go into the primary care world, when patients are being seen and evaluated for their headaches and trying to figure out what's going on, you can see here in one study where they actually went through the appropriate questions to assess for migraine, tension, or other types of headache disorders. You can see that the vast majority of patients, over 90% of them, actually were also migraine. And we see this in the world of neurology, and we also see this in the world of the headache centers that many of us run across the country. So it is really a common problem to be aware of, that the vast majority of patients, again, statistically speaking, will be coming in ultimately, despite the number of symptoms that a patient might have, with migraine. Now, it's important to recognize, though, that migraine is not as common as tension type headache. The reality is, though, is that generally when it's a tension type headache, it is something that is usually well managed at home, not causing significant disability, and therefore you as a patient don't feel the need to see a provider. But if you're going to see a provider, generally speaking, that's because you've reached a level of severity, whether it be moderate or severe, whereby you feel like you need to get assistance and try and figure out what this is. Now, just to throw a little more background about what migraine is, specifically in terms of how prevalent this is, how common this is that it actually affects at least 38 million Americans, if not more now, as the population continues to grow. And that's about 15% of the entire population of the country. On a global scale, the numbers are actually very similar as well. So you're talking millions and millions and millions of Americans, if not millions and millions of people across the globe, have this problem. And it does seem to affect young, healthier women more so, females more than males, by a 3-to-1 ratio. And it affects 18% of all females. So in fact, if you go down, a mall or a shopping center, or just in the hallways of a hospital or a practice, you'll find that 1 in 5 people that you pass by that are female will likely have a migraine as well, similar to what you might be experiencing. It's just that people don't talk about it. And in part because, again, as I mentioned before, there's really no test that we can use to confirm the diagnosis. It's a clinical diagnosis based off of the history that the patient provides. And unfortunately, that creates a little bit of a stigma, because if we can't see it, there's no cast on the arm, for instance, then people don't recognize that it is a real problem, and many people are struggling with it. So while you've got 18% of adult females that have this problem, it's 6% of adult males generally have this problem. And then on top of that, what we will do is, as clinicians, is we will then try to figure out if you've got a diagnosis of migraine. We'll split it between what's called episodic migraine, meaning that you've got less than 15 headache days per month, or 15 headache days or more, which, to be frank with you, it's an arbitrary number that was created by the headache specialists of the globe many years ago. And that number is actually being debated right now, presently, to see whether or not that's the right number to utilize. Some would actually argue that 8 headache days should be considered chronic migraine because of the known disability associated with it. But needless to say, when you've got a chronic migraine diagnosis, that's 1 to 3% of the population. And there's more than just chronic migraine that can cause chronic daily headache. That is actually a primary headache disorder affecting patients 15 days a month or more. And that's about 3 to 4% of the world's population. So in Pennsylvania alone, you're talking over 500,000 people actually have chronic daily headache by definition, that may or may not be getting treatment. And given that there's only approximately 700 headache specialists that are certified across the country, we have a lot of work to do to make this a better world for everybody. And frustratingly and sadly, in part, maybe because people think that having a headache disorder is normal, or that having to sleep on the couch for a couple hours is normal, or having to be bedbound for a couple hours, if not a whole day, is normal, they may or may not go seek support. But then the question becomes, once they seek support, does that provider, the clinician that they're seeing, recognize that this is a migraine disorder? And the reality is, unfortunately, almost 40% of the patient population will not get the diagnosis of migraine for at least 3 years from the point that they start having symptoms. And I see this all the time in the inpatient world, particularly when I'm being consulted for a, quote, new headache. And then I start doing a deeper dive into that history with a patient to discover that, oh, well, they've had infrequent headaches through their lives, maybe menstrual related, maybe sinus related, or maybe just tension that required a number of hours to get under control. And those were actually migraines just misdiagnosed or not diagnosed at the time. And what's frustrating and sad for all of us is how young this can actually start. What you see here is the migraine prevalence on the left-hand side. That's the percent of people across the country, and the years that go on the horizontal. And you could see that migraine actually can start even as young as 4 or 5 years old. I remember when my daughter started mentioning to me at the age of 5 years old that she had this complaint of a booping that was going on in her head, and she couldn't understand what it was. Well, that was her first migraine. And so what you see, interestingly enough, is that boys being in yellow and girls being in purple, until you get to about the point of menarche, whereby girls are starting to have their menstrual cycles, it actually is a little more common for boys to have headaches than girls. And then it changes over to being more of a girl-related challenge. And that unfortunately continues through our lives and really peaks into the 30s and 40s, as you can see. And this is where it can even begin, even into the 50s. And then it seems to start tapering down once you start getting into menopause levels for boys and girls, arguably. And then it starts calming down, but it doesn't necessarily go away for everybody. In fact, approximately, as you see, between 5 and 10%, I would say, of people are still struggling with headaches into their 60s. Oftentimes, those are the ones that are seeing me. And sometimes they can develop headaches at the point of past menopause. And then they have to figure out what that is. And of course, that's where red flags start kicking in first. making sure there's not any other issues. And then we go back to the primary headache diagnosis like migraine, if that ultimately is the right direction that we need to go. And so from a neurologist standpoint, migraine really is the most common reason for referral to neurologists. And it's the second leading cause of years of life with disability worldwide. Not the American Headache Society, not the International Headache Society, not headache specialists, but the World Health Organization has suggested that migraine can be as disabling as quadriplegia. Not to say that you've literally lost an arm or a limb, but the degree of disability associated with it is truly impressive and significant. And 1 in 3 patients will actually avoid planning activities because they fear having to cancel it. The last thing that you as a patient would want to do with a background of migraine is to plan a really nice dinner or going out to a great movie. And then in the middle of that dinner, in the middle of that movie, develop one of those headaches that you don't have a good rescue medication for, and you get debilitated in those settings, you have to leave. It is quite embarrassing. And again, given that people can't see your headache, they don't see a cast in your arm, they don't see any objective evidence that you're suffering, it is quite a disorder of stigma, which is a problem for still a lot of patients. Admittedly, thanks to pharmaceutical companies now for the commercial that they have with Serena Williams and others now to really broadcast that migraine is this neuroinflammatory state of the brain, to help people recognize that this is not a disorder of just emotions, but this is a disorder of the brain itself, I think has helped a lot to decrease that stigma, but I still think we have a long way to go in this process. As I mentioned before, a lot of people suffer with moments of needing bed rest. In fact, more than 50% of patients will actually have attacks severe enough to require bed rest. But I will emphasize to you, please do not think that migraine has to be severe and disabling to have a diagnosis of migraine. Again, you can have a moderate migraine. In fact, arguably, some people will have mild headaches as well as severe headaches, or they'll have mild and moderate headaches, and it can be on a spectrum in terms of severity. So you might think those mild headaches are actually just tension headaches, where in reality, they might be just mild or migraine headaches that you're experiencing, thankfully not severe, but still migraines ultimately in the process. And then the other issue that comes up is missing work, which would be called absenteeism. But there's also something called presenteeism, where you go to work, but you're not working on all cylinders. And in that context, your productivity is down. So the employers are also struggling with challenges with you as an individual who's suffering from this disability that is not being addressed effectively enough for your purposes, which is, again, another problem. Now, migraine can come in several different phases, and this doesn't have to happen for every single person. That's an important detail. So for some people, you might have what's called a prodrome or premonitory stage, whereby it's ahead of the headache, even days ahead, where they could feel fatigue or nausea, irritable. They can explain why they're, starting to fight with their significant other. They can have mood changes, appetite changes. They can have later sound sensitivity at these moments. And that could be ahead of the headache without having the headache pain, but these features. And then for some people, they can have an aura, and generally lasts between 5 and 60 minutes, although it can last a full day depending on the auras. And sometimes people even have this during the headache as well, where they can have vision disturbances, double vision, loss of vision, numbness or tingling, weakness, dizziness, room spinning, vertigo, feeling like you're on a boat, which we also call mal de débarquement, which is French for getting off the boat badly. And this will affect actually 1/3 of patients, but not all. So 2/3 of patients do not have an aura, only 1/3 do. And then if they're so lucky, they can have a headache that looks, that is, has this throbbing quality. It can be moderate or severe, it can be one-sided or both sides or side switch and go from the front to the back, to the back to the front. They can have lighter sound sensitivity. And I want to emphasize, though, when I say sensitivity, this doesn't mean that it has to be blinding in order to say that you have light sensitivity or what's called photophobia. It could be mild. So as I describe to patients, oftentimes I'll say, well, if you're at the beach midday, sun beating down on you, if given the choice, would you prefer with that headache and maybe a little bit of light sensitivity to be in a quiet or a darker room, for instance, or go to the beach a different day? If the answer is yes, because the light does bother you a little bit, that counts to create the associated symptom of photophobia, or light sensitivity. And then on the flip side of this, for sound sensitivity, I'll ask patients, well, could you go to a rock concert or a country music concert? Choose your music of preference. With your headache, if given the choice, would you rather do that concert another day because of the sounds that you might be hearing? If the answer is yes, then that will be sound sensitivity or phonophobia. And then some people have nauseousness or queasiness, sometimes vomiting. It could be worse with movement. Certainly, that's a common problem. They prefer to lie down. If they say to me that they're not really worried about movement, then I'll extend this a little bit and say, well, what about going up and down stairs? Would that bother you? If given the choice, would you rather be lying it down? Would you rather avoid jumping jacks? If you truly have just a tension type headache, those things generally do not bother you very much, if at all whatsoever, which is an important detail. And then after the headache is over with, people can feel actually fatigued and tired, have the sense of brain fog. Now, it might be because of the medications that they're taking to stop the headache, because they're trying to suppress that neuroinflammation that we'll get into in a moment. But it could also be because that the headache, just by default of it, is causing these symptoms thereafter. So these are some examples of auras. This is, as you can imagine, someone was on the ski slopes when they experienced these types of feelings, these sensations. So you can see the snow in the top left, where you've got these kind of zigzag lines on the top right. Those zigzag lines are actually in the sky above the ski slope. And then they can also have what's called phosphenes, or this globular dots that can come out in multiple different colors. It could actually be very pretty, but it's not very pleasant ultimately if you're losing your vision and or it develops into a headache thereafter. And sometimes they'll have this kind of zigzag line that kind of creates a circle. And in the top left, you can see where it starts. And it kind of just expands outward as time goes on, as it goes across the screen, as you can see on to the right, to the point where it becomes this very large, kind of this multicolored thing that you see. And we call this fortification, whereby you see the zigzag line and then the loss of vision in the middle of that text, for instance, as you can see here. And the rationale behind this is that the zigzag line is the neurons firing off, creating this almost like a seizure, but it's not a seizure. It's a well-formed, organized, event that occurs in the brain. And then once the neurons fire off or depolarize, then they go to a hyperpolarized state where they can't fire off temporarily, and that causes the loss of vision that you experience in the setting of this aura. And this is what's called fortification specifically. And the reason why we call it fortification is that what you can see here is that the idea came from these old bastion forts that sometimes are actually still in the Caribbean and in Spain, just to see how forts may have been structured back in the day. So if you're looking at the fort overhead, you can see how that might relate to each other. Okay. So I mentioned that, there's not only just migraine, but there's other primary headache disorders like cluster and tension type headaches. And these are the most common primary headache disorders. And it's interesting because I get a lot of people that will tell me that they have this cluster headache. And I'm like, well, explain it to me a little bit more in detail. And so they explain to me that they'll have a headache that lasts for a number of hours, for, 5, 6 hours, and then it'll go away. And they'll have another headache the day after, and another headache the day after. Well, that is definitely a cluster of headaches, but that is not a cluster headache disorder. A cluster headache disorder, unlike migraine, is a disorder whereby it lasts only between 15 minutes and 180 minutes untreated. In other words, it'll go away in 3 hours without any medication, whereas migraine untreated, it might go away that soon, but generally speaking, untreated migraines last 4 hours to 72 hours, and frankly, even beyond that, to multiple days, weeks, or even years. I have many patients, unfortunately, who suffer from daily migraine that extends for decades, unfortunately. It can be very, very challenging for some people to get these headaches under control despite best efforts. Tension type headache can also extend for a long period of time, but that one is more of this band-like pressure sensation squeezing across the head, whereas that migraine is typically that throbbing quality. But of note, migraine can also be pressure. Sometimes that pressure can kind of go in and out, which is where the throbbing can come from, but sometimes it can be milder early on, at least in a pressure format. Whereas a cluster can be acute onset, severe, debilitating in the process. And the other thing to note is that cluster is effectively just one-sided. It does not go to the other side. It is side locked, as I call it. Migraine affects women more than men. whereas cluster is more common in men than women. Tension type can be either sex, frankly. Migraine patients like to lie down in a dark, quiet room, whereas cluster patients might like to pace. Sometimes I describe it as like chickens without heads on, because that pacing is a distraction from the pain that they're experiencing, and that's the only way they can do it. I used to have one patient who used to bang his head against the wall to get relief. And this is, again, an important detail in terms of why it's so important to get the right diagnosis, because the medications can be different between, migraine and cluster and even tension type in terms of what we use to get the best outcomes early on. Cluster, for instance, really benefits from oxygen, whereas migraine really will not benefit as much. And tension type will benefit from your simple analgesics, maybe a muscle relaxant, and other specific medications. Migraine will have, again, as I mentioned before, this nausea potentially or light and sound sensitivity. They could actually have autonomic features, which includes eye tearing, eye redness, eyelid droop, runny nose. But that's usually both sides of a person's head, whereas cluster will be one side, again, side locked, never changes between the two sides. Tension type, on the other hand, won't have those autonomic features. It certainly won't have that throbbing quality. And interestingly enough, it could have light or sound sensitivity, which can make things a little confusing, but it doesn't have any nausea associated with it. Now, this can, of course, be a little complicated. And, ultimately, as clinicians, we need to memorize this type of data to try and help figure out which problem the patient is dealing with. But to really just kind of simplify it and make this really quick for a primary care provider, and or even from a patient's perspective, this might be a good way of assessing where you think your headache might be. So if you just ask yourself these three questions, or your primary care provider asks you these three questions, you got a good probability of figuring out what diagnosis are you dealing with. So has the headache limited your activities for a day or more in the last 3 months? Are you nauseated or sick to your stomach when you have a headache? And or does light bother you when you have a headache? If you actually have two of those three, you have an 81% probability of getting the diagnosis of migraine by default. So that just really simplifies it, if in case you're not interested in memorizing all the other criteria that are associated. And if you really want to know the criteria specifically, the International Headache Society, or IHS, and you just Google that and you put in classification, and all the different headache disorders will pop up, and you can read them, disease after disease after disease, to try and figure out where could you classify, for instance. Okay, now I'm going to put all of you in front of the patient as a clinician, and your job is now to figure out what headache diagnosis does this particular gentleman have. So I'll give you all 5 seconds to think about that for a second. Okay. All right. So in my opinion, as a headache specialist, I would argue this gentleman is suffering from a tension type headache. And why do I say that? Well, it's both sides. It's pressure. It's a male, not a female. He actually almost looks like he's smiling in the picture, suggesting it can't be that, severe. And I think his eyes are open. So he doesn't have light sensitivity. It's not too severe. It's a bilateral pressure sensation. So I would argue this is probably a tension type headache that this individual is experiencing. All right, let's switch gears and now talk about migraine a little more in detail. So what is migraine? Well, it's a genetic disorder. Again, statistically speaking, many of my patients happen to be female just by default. That is a more common problem amongst females compared to men. So usually what I'll tell that particular patient is that she can blame her mom for her headaches. And certainly if she has kids, the kids will blame her for their headaches, and so forth. Because though it is genetic, we can't cure it. We have no treatments to address it. So any physician who ever tells you that they're going to cure your migraines, never believe them, because that is not accurate. We can address the triggers that cause migraines, but we can't cure the underlying mojo that most people are struggling with. The idea is to figure out how to manage this best until the point where basically it burns out once you get to menopause, typically for boys and girls, arguably. It is a brain disease. And as I described to my patients who see me for that first visit, it's a neuroinflammatory pain syndrome. So it's kind of like 3 dings on you. So your first thing is you've got this general inflammation. So if you bang your arm, it gets red, swollen, inflamed, those same general inflammatory chemicals are going on in your head. That's your first ding. The second thing is that you've got these specific neurochemicals that are in your brain specifically that are going off and causing trouble as well. So that's your second ding. And the third thing is the nerves are firing off more regular than they should. And then the process of all of this, as the nerves are firing off and the inflammation's going, the blood vessels can dilate, and perhaps that's causing some of that throbbing quality that you experience if you've got migraine. And on a more picturesque way of looking at this, what you can see here is that you've got this peripheral nerve that's connected to the blood vessel, which is also connected into the layers of the brain called the dura mater, and that sends signals and information from that neuron peripherally into the central nervous system, into the brainstem specifically, and then all the way up to the brain through into what's called the parietal cortex, which is your sensory area of your brain, and that triggers that sensation of pain that you experience. And as a result of this pain process, it can cause headache pain and facial pain in the front. It can cause neck pain in the back, and even sinus symptoms. A lot of people present either by their own diagnosis or their primary care diagnosis as sinusitis, when in reality, actually, and frustratingly, it's actually migraine that they're dealing with, because there's these nuclei in the brainstem whereby you've got one that's involved in pain, the other one is involved in those autonomic symptoms I mentioned to you, whereby you can have that eye tearing, eye redness, even eyelid droop, runny nose, and that can all be due to the pain that you're experiencing. Now, admittedly, if you've got yellow schmutz coming out of your nose, if you've got a fever, sinusitis sounds like a very, very fair direction to go. And certainly sinusitis can also cause migraine. But there was a large study done a number of years ago looking at almost 3,000 people who were diagnosed by themselves or the primary care provider with sinusitis, and over 90% of them, in the setting of going through the appropriate classification criteria, turned out to be it was migraine, not sinusitis. All right, so let's switch gears and start talking about treatments. How do you manage this challenging headache disorder that can put you down for hours at a time, if not days, can make you lose, your ability to work to go to work, to go to school, challenges with your significant others. How do you do this? How do you manage this? Well, it really comes to three key areas. And this is how I describe my patients when they see me for the first visit. The first priority is lifestyle. How do we avoid the triggers, understanding what those triggers are? The second component, if necessary, are what's called preventive medications. And the third component are acute medicines or abortive or rescue medications, depending on the terminology you want to use. But most importantly, at least in my opinion, it's trying to figure out the lifestyle decisions that will really mitigate the risks of you having this challenging headache disorder. And yes, don't get me wrong, if you see me, more likely than not, I'll throw you lots of different medications to try and help you. But the idea is to try and avoid drugs where we can in the process. So there's a wonderful study done many years ago by this physician, Dr. Kelman, who looked at what are the causes or the traditional triggers and causes for people with migraine. And I will tell you up front, though, that there was a recent study that was done, I don't know if it was published, that really suggested that if you really want to isolate each individual variable, it would only take you 1,261 years to accomplish that. So more likely than not, you're a little late to the game unless your name is Dracula. So at this point, there are certain ones that are just common that we are aware of, we know, work off of those. Certainly, you can try and isolate those individual ingredients that might be causing your headaches, but it is very difficult because particularly those of us who live in the northeast of the country where the weather gets finicky, so you got barometric pressure changes, temperature changes, maybe going from a heated environment to a cold environment with air conditioning and vice versa. All those things play in. But needless to say, if I had my druthers in terms of what the causes are, and this is well established, stress is the number one, number two, number three, number 10 reason why you could be having your headaches trigger in the first place, whether it be, stress with your significant other, issues with your job, issues with your kid, finances, or any number of other issues that might be playing a role. Stress is the number one reason why people actually will trigger into their headaches. One of many reasons, but one of the most prominent ones. According to Dr. Kelman, the next one is hormones. So certainly during menstrual cycles, ovulation cycles, that could be a large issue for women. You guys do get the bum rap of this deal in many respects. If you don't eat well, that can trigger headaches as well. I generally tell people every 3 to 4 hours, you should be hydrating, certainly, maybe cheese crackers as well, because if your sugar levels drop, that's going to kick you off into a headache potentially. So it's really important to maintain this basal level of hydration, nutrition, and just stability overall, because migraine brains like the merry-go-round, nice and boring, not the roller coaster where you're going up and down. So stability is really the name of the game. As I mentioned, weather can play a role. I generally find that fall is the worst time of the year because the barometric pressure and temperature changes, as well as just the ambiance is getting a little darker and drearier, arguably for some people. Winter is the second worst because probably it's just drearier and darker. Third worst is generally the spring when the barometric and temperature changes are again occurring. Summer is the most stable time for the majority of people. That's when we get the less phone calls and admissions to the hospital. Sleep disturbances are another large issue. It's really important that you go to bed a certain hour, wake up a certain hour, not deviate more than an hour or two, because if you do so, that can disrupt your circadian rhythms, and that can cause, again, a disruption in your flow. And as a result, that can be another reason why you can develop your headaches. If you have wake-up headaches, that can be due to migraines. It can also be due to your neck concerns. For boys and girls greater than the age of 50, though, if you have wake-up headaches by default, you should be getting a sleep study because sleep apnea is a common problem to have happen at that point as well. Perfume and neck and odors and such can also play a role for a number of people, but neck pain is a large concern. During my first visit with every patient, as well as all follow-up visits, if we're doing an examination, one of the things I'll ask them to do is actually see if they can touch their shoulder to their chin. As you can see, I can do this pretty readily, still at this age, which is wonderful. But a lot of patients can't, which suggests that either they have muscle tightness, they have arthritic concerns in their neck, or their stressors are so significant it's coming out of neck and shoulder tightness. And by the way, stress will come out commonly if it's not being vented effectively, verbally or other ways. It will come out in neck and shoulder tightness, jaw tightness, stomach irritation, and or headaches. And so that all works into your head. The headache can also cause neck and shoulder tightness. Neck and shoulder tightness, again, can cause headaches. Jaw tightness can cause headaches as well. So a comprehensive approach to you as an individual, if you've got a background in migraine, is really critical in the name of the game to get the job done. If the neck tightness is significant and or you've got spasms in your neck and shoulders, physical therapy may be a nice option as well to help you learn to stretch more effectively. While if stressors are playing a role, you've got an option to address. Dentists may be needed for TMJ as well. To have an appliance so that way you're not biting down, for instance. I also look at people's teeth the first visit. If you've ground down your teeth, that would suggest you've got something called bruxism, which can be due to some muscle disorders, but can also be due to stress, and that's where you're relieving it. Alcohol, certainly a lot of people with migraines can't use it or drink it. Sometimes some people can. Sulfites tend to be a larger issue in that context. From a food standpoint, people have issues with nitrate-containing foods, processed foods. So even your turkey or chicken sausage that you might have for breakfast could play a role for some of your headaches as well. So as I mentioned, in terms of some of those non-medicine approaches, stress management is really important. Anything from the Headspace app to the Calm app for simple meditation. If you're not sure you can meditate effectively enough, you're not sure you're doing it correctly, biofeedback becomes the next step, whereby you put your fingers in these electrodes, and as you relax, the temperature in your fingers actually goes up. And as a result of that, that is a way of meditating to get you where you need to be. But the beauty of biofeedback is that that information on the temperature actually gets transmitted to a video screen to let you know you're doing it correctly. So you're getting that biological feedback to let you know you're doing it correctly. And this is actually one of the few things that have been demonstrated non-drug to be effective for people with migraine disorders. As I mentioned, physical therapy, and then there's traditional acupuncture. I will caveat that it's hard to find someone that's really good. That is effective in particularly in the migraine and neck and shoulder spasm space, and it is still somewhat controversial in the literature as to whether or not it does make a difference. Okay, so let's get into a little more aggressive treatment options, if you will. Because neurons are electrochemical, not only can we treat migraine from a chemical standpoint like medicines, we can also treat it from a stimulation standpoint, such as these devices, such as the Cephally, which sends little signals. It's kind of like a TENS unit across the forehead. The Gamma Core, which is a device that you can stimulate the vagus nerve to try and send electrical signals up to stop headaches. And Nerivio, which is a stimulator that you put in your arm that sends electrical signals up to the brain as well. And Nerivio has actually just been demonstrated to be effective, not only to abort headaches, but also potentially prevent headaches as well. So spend some time talking about non-drug options. Let's spend a little bit of time talking about preventive medicines first, and then we'll go into acute medications. So there are a lot of medications available on the market, and this is actually just a very, very small list of them. What you see on the left-hand side are what we call the non-specific medications. And these are medications that we've discovered over the years can be effective for patients with migraine. And just at the top of the list, vitamin B2, magnesium is drugs of choice, if you will, non-prescription, over-the-counter, B2 400 milligrams or magnesium 400 milligrams. The nice things about these is they're very mild, low risk, potentially good yield. I find particularly for people who are not significantly struggling, but are looking for management without a prescription, for instance. And then you've got seizure medicines, you've got mood medicines, you've got blood pressure medicines. And I put these in quotes specifically because while these drugs were not created for the sake of migraine, they've actually been demonstrated to be effective, and several of them are FDA approved for migraine too. And the way this worked out is because patients would be getting these medications for their different diseases, and then they would tell the providers, oh, I actually feel better from a headache standpoint, which then prompted researchers to then restudy these drugs specifically for the sake of migraine, for instance, and found out that they were effective. So even though we as providers might prescribe these medications for you, they may not be for mood medicine, mood or seizures or blood pressure. They may be solely for your headaches, but we found them to be very effective for migraines as well. Even botulinum toxin was initially, of course, used for aesthetic purposes, and those people that were getting it aesthetically found that it was actually working for their headaches, which prompted the research to occur to demonstrate that botulinum toxin can be actually used very successfully for people with migraines as well. But again, that wasn't the original purpose of it. But now that we understand these different medications and migraine better, we've been able to create medications that are actually designed for migraine, starting with this new class of medicines called the monoclonal antibodies, whereby we recognize is one chemical called CGRP that floats around in the brain, also in the body too, but particularly in the brain. If we block that neurochemical from going from nerve to nerve, we can shut down migraine for some people. And I say some only because migraine is a complex disorder. There are multiple different pathways involved that cause migraine, and this is one pathway. So we unfortunately don't know for any particular patient which pathway or pathways are active, but we do know this is one of the key pathways for many people. So by giving a monoclonal antibody that specifically either goes after that CGRP and blocks it, or the receptor so the CGRP can connect to the next nerve, then we've got something to work with and stop headaches. The GPANs are another class of medications that are more recent, and they are what's called small molecules, and they go on the receptor to block the CGRP from connecting from nerve to nerve. Now, as one who does a lot of headache, one of the things that I try to do, as well as many of my colleagues and as well as my colleagues in my practice at Abington Neurological Associates, is trying to figure out, with all these different medications available, which one is best for you as an individual. And as you can see, there's many choices, but what we try and do is figure out, well, maybe we can kill more birds than with one stone, if possible, with one particular medication. So for instance, if you have high blood pressure, we still could use those blood pressure medications to try and address that problem, as well as your headaches. If you have poor sleep or mild mood disturbances, there are specific medications for that purpose. If you have poor energy levels, there are medications for that. If you have a burning sensation, we might use other medications as well. So there's lots of different ways to finesse this to try and be more specific to your needs and provide a customized approach if the provider is so inclined to try and assist and is aware of these different medication options. And then the third part of 3 are the acute medications. And I will emphasize, though, that yes, if you have, let's say, 4 headache days per month, an acute medication is generally all you're going to need, but maybe those headaches are so disabling and maybe the acute medications aren't working that maybe a preventive is still necessary to prevent the disability that you're having with your headaches. Generally, we used to think that 15 headache days was the typical number that you needed for preventive purposes, but now we've discovered that with disability associated with even 8 headache days or less, preventives may be appropriate even down to 4 headache days, depending on the significance. But acute medications might do the job particularly very well for infrequent headaches. And if you're really frequent, they still might be of great value to you as well. And generally speaking, everyone leaves my office with at least a few acute medications, and or they'll leave my office with acute medications with preventive medications as well, depending on the needs. And just like I mentioned to you before, there's lots of preventive options on the market to get the job done. There's also lots of abortive options, and this is a very small list of the possible choices available to you. That includes NSAIDs, and any NSAID might be appropriate and effective. The nuance to this is that every drug has a half-life, and generally speaking, what that means is that the drug will be metabolized in your body, and the half-life is the amount of time it takes for half the drug to get metabolized. So generally speaking, a drug like Advil, for instance, also known as ibuprofen, also known as Motrin, will last between 6 to 8 hours in your system, whereas naproxen, on the other hand, also known as Aleve, will last between 8 and 12 hours. So the probability of you needing another drug is less with a naproxen versus an Advil, potentially. But again, it's all customized for the individual. We also find that anti-nausea medicines can also work quite nicely for headaches, not just for the nausea, but for the headaches, because particularly the medicines that you see here, like Regla and Compazine and Zyprexa, can have some specific neurochemical changes in the brain that seem to suppress headaches and calm them down and make them go away as well. And even one antispasmodic, Xanaflex, also known as tizanidine, has some pain modulating properties. And then the specific medications that were designed for migraine actually started in the 1940s with ergotamine, specifically DHE. However, in the 1990s, we discovered or created triptans like sumatriptan or Imitrex, rizatriptan or Maxalt, and those medications have been very effective for a lot of people, and they're also very inexpensive and easy to get. The newer medication classes at the same kind of breath are ditans, for instance, lasmiditan specifically, which is also known as Rayval. This is kind of like a cleaned up version of the triptan. And then GPANs, just like I mentioned to you before, work on the blocking that receptor of CGRP, and that can be utilized as well to break headaches, and specifically Ubrelvy and Nurtec in this example. And again, we can also finesse the abortive medications. So that way, if you have certain types of headaches that you're struggling with your background, let's say that your headaches escalate within 5 minutes, there are medicines that are injections or nasal options that can work very effectively and powerfully for you to get you relief in 15 minutes or even less potentially. If you've got menstrual related where they're just multi-day, then we can concoct a certain way of doing the abortives to give you that relief, so that way you're not suffering through that. Or maybe you're someone who just really struggles to find the moment where the headache begins before you treat, and it takes you a couple hours. Of course, that's a problem in its own right, because migraine starts as a snowball and becomes an avalanche. So you always want to treat as early as possible in order to break the headache, because if you wait when it's an avalanche, it's much more difficult. But there are some ways to get around that if we need to. If you've got cardiac concerns, you can't take some of these medications because of risk of cerebrovascular disorders and potential coronary artery disease events that could cause heart attack and stroke. So we have to be aware of other options available. And if you've got significant GERD or ulcers in your stomach, then of course we want to be cognizant and give you other choices in the market as well that would be more effective for you. So I hope ultimately at the end of this presentation, I haven't given anyone a headache in this process. I admit to you that generally after the first visit with me, it's kind of like drinking out a fire hose to try and absorb all this information. But this presentation is kind of similar to what my first visit is like for many patients. So usually I give a headache before I start helping to address the headaches effectively. But if you're asking me, what would you do when you're going to see your provider, whether it be your primary care provider or your neurologist at Abington Neurological Associates, I would suggest to you a few things. Number one, keep a frequency of the attacks through a diary. How many days per week or per month do you have headaches? Let's quantify this, because ultimately with that quantification, I know several different things. One, do you have an episodic headache problem or a chronic headache problem? And number two, if you're on preventive medicines and you still have high frequency headaches, then that preventive medicine, either because the dose isn't high enough or the drug isn't working for you well enough, we would switch gears and change things up. If the average, and then recording your average severity of attacks, 0 to 10, 10 being the worst pain you can imagine. If the severity of the headaches is high, then there's potentially significant disability. Maybe we need to consider a change in your preventive or change in your abortive. And the third is the average length of each attack, the duration per attack. Is it minutes or hours? If it takes you 12 hours to get relief, then the abortive medication that you're utilizing is probably not sufficient as it's written. Again, maybe the dose isn't high enough, or maybe the drug itself isn't good enough, or maybe you need to try a combination of options simultaneously to get the job done better. But having that quantification helps us clarify whether or not we're doing justice for you each visit. And then certainly if you're seeing your provider for the first time, really capture all the medications that you've tried and failed. So that way, when we see you, you're not reinventing the wheel and thinking that, you know, you're just wasting time on the visit because you already tried these medications because there's so many other options on the market. So hopefully you've gotten a good sense that, you know, this is a really common problem and you really aren't alone in this process. But if you still feel concerned about that, or you're still struggling to find the right solutions, this is a wonderful website to go to. This is the Coalition for Headache and Migraine Patients. What they've basically done is brought together most of the major national headache organizations, patient-related organizations, under one umbrella group to try and make sure that you as a patient can communicate with each other and figure out what's going on with each other to try and help each other as well as you go forward, and other opportunities that might be in front of you that you might be missing the boat on. So it's https://headachemigraine.org. And so in conclusion, I just want to say and emphasize how common migraine really is. It can certainly be disabling. It doesn't have to be, but it can be. And it has lots of different symptoms. And so when you're experiencing all these different things, you don't need to feel necessarily overwhelmed that this is something only you. It could be, and it could be any number of different things, but more often than not, it is a challenging disorder because of all the different ways it can approach and occur. But it can be successfully treated with many non-narcotic medications. In my world, and as a headache specialist, we do not use Furoset. It's generally a drug that we really only reserve for the worst case scenarios when patients have tried any number of other medications, because there are risks with that, including what's called medication overuse headache. But I hope you can see that there's lots of options on the market that are non-drug, as well as medications that are very viable. And with that, I will end and just say thank you so much for the opportunity to chat today, and hopefully this was useful. I'm going to switch to the chat box now and see if there's any questions that have come in since I've been speaking. All right. So I'm being asked whether or not this will be recorded and available to participants. I'll defer to my staff at ANA. I assume this will be recorded. No, I'm sorry. This was recorded, and I'm sure this will be up on our website. I would hope. Can you explain the relationship between headaches and vertigo? Oh, it's such a challenging question to answer. Vertigo comes from lots of different places. My colleague, Dr. Klein, was mentioning that in his prior lecture a little bit as well. First I would emphasize that admittedly, for when a patient presents saying that they're dizzy, I have no qualms with that. But when a provider, a colleague of mine, tells me that, this word dizziness, it gives me the heebie-jeebies a little bit, because dizziness doesn't tell me where the problem is coming from. What I like to do is I like to break it out, and certainly encourage you to, consider these words when you're talking to your provider. Is it lightheadedness? Do you feel like the room is spinning horizontally or vertically? Or do you feel like you're on a boat? Generally speaking, when people feel like they're on a boat, or that mal de débarquement I mentioned before, that generally I've seen in the world of migraine specifically. I've seen it in multiple sclerosis on a few occasions. And specifically, there's one part of the brain that seems to trigger that as well, which I've seen in one person with stroke. But generally speaking, I see this very commonly in the world of migraine. And I do see that a vertigo can, of course, occur in the world of migraine. And so, migraine is this hypersensitization of the brain. So the reason why you have light or sound sensitivity is because you have this increased sensitization towards sensory stimuli coming in. And light is one of those things that you appreciate as a sensory stimuli. So the way I see vertigo in the world of migraine is that you also have part of your brainstem involved, recognizing where you are in space and your equilibrium centers. And so I suspect that what's going on in the context of vertigo is that part of the brain that's sensory related is just firing off more regularly and much more easy to be stimulated, just like you can be overstimulated with light or sound or smell. And that's more likely part of the problem when we're dealing with vertigo associated with migraine. And frankly, trying to suppress the headaches might also suppress the vertigo, or utilizing headache medicines in the context of migraine with vertigo due to migraine, you can go after the vertigo through those migraine medications. We hope. All right. Let's see, what other questions have come in? Yes, so I did get a message from our staff, David Moore. The recording will be available on our website by the end of the week. It'll be displayed on the homepage. Any information on vestibular migraine, I hope I explained that a little bit enough to work off of. If not, please let me know. Certainly you can reach back to me through ANA as well afterwards. Can you speak on concussions and headache? Yes. So concussions is a challenging state. What ends up happening is when people have a concussion, either they've actually hit their head or they've had a closed head injury where their head bobs back and forth, and ultimately their brain actually touches the skull in the process. That can still cause the same kind of trauma as you could if your skull hit, the steering wheel, for instance, as it occurs in some motor vehicle accidents and other types of problems. I had one patient who unfortunately banged her head against the cabinet, the drawer that was out, and ended up developing this post-traumatic headache from it, unfortunately. And so when we're talking about, what does that mean for the patient? Well, concussion creates this inflammation of the brain, similarly in some respects to migraine. While we don't have all the things worked out, it does have that same kind of inflammatory state. And I kind of wonder whether or not, we're using the word migraine appropriately versus representing that migraine as a symptom of the inflammation that we have in our brain, and a post-concussion syndrome or post-traumatic headache that can come out of this can look very similar. And yes, you can have nerves that are sheared and stretched in the setting of a concussion where due to injuries to the nerves, but still that inflammatory state is still the same ultimately. And we actually treat it very similarly, whether or not you've got a post-traumatic headache or a migraine, because we do find that the approaches are very analogous in terms of working and being effective for patients. Hopefully that answers your question. But I will say, though, in post-concussion syndrome, there are other features that come up that I have to worry about. These visits tend to be longer for first visit till we try and clarify this, as some of my patients know very well, because post-concussion typically oftentimes includes dizziness, cognitive concerns, as well as emotional concerns. It can also cause eye problems, and all those things have to be worked out in the process. So next question is, you mentioned one of the phases of migraine could be numbness and tingling. Where would you feel this? Numbness and tingling can unfortunately be anywhere, which is very, very frustrating. It could be anywhere from an arm to a leg to a face. I can see to you, generally, I have not seen a facial droop due to migraine. I always worry about that from a stroke standpoint, but can occur anywhere. Ideally, it goes away as the migraine progresses, but certainly if that's the first time you've experienced that and you haven't gotten the right diagnosis yet, or it's not clear what the diagnosis is, you haven't confirmed it's not some other neurological concern, I would certainly pursue that. But then once we've established the diagnosis, we generally don't chase it very frequently if it's a repeating symptom that you have as part of your migraine presentation. The other question is, what dose of magnesium is effective? We usually use 400 milligrams. All right. Well, if no additional questions, thank you again for attending. I hope this was helpful, informative. I really appreciate your time, and I wish you all the best of luck. Take care.